Good morning to all. I am Dr. Mody, first year DMB cardiovascular. Today I am going to discuss on the topic Takotsubo cardiomyopathy. First, with the history of the disease. First case was described in 1990 in Japan. It was noticed that patients presented like acute MI like presentation but had normal coronaries and LV dysfunction was transient. Then in the early 2000s, cases began to report and was increasingly recognized as a distinct entity. 2004, Mayo Clinic proposed a diagnostic criteria for the disease. 2011, largest multicentric registry was formed, which is called as Intertype Registry. And 2010 to 2020, further broader pathophysiological insights are being formed. Takotsubo cardiomyopathy is called so because Tako means octopus and Tsubo means pot. So the shape of the left ventricle is similar to the Japanese pot used to catch octopus. Another name of it is stress cardiomyopathy or broken heart syndrome. It is called so because it is triggered either by an emotional stress or a physical stress or emotional trauma. It is also called as transient apical ballooning syndrome. Because there is ballooning of the apical segment of the left ventricle while there is hypercontractility of the basal segment. So it is called as transient apical ballooning syndrome. And another terminology is called as neurogenic stunned myocardium because it is triggered by neurological or psychiatric events like subarachnoid hemorrhage, seizures, anxiety, depression, etc. So as you can see in the image, this is the LV angiogram in which you can see that the base of the left ventricle is hypercontractile and the apex is dilated. So this is similar to the pot shape which was used. So it is called as Takotsubo cardiomyopathy. Takotsubo cardiomyopathy is basically a clinical syndrome characterized by acute and transient, less than 21 days, left ventricular systolic and or diastolic dysfunction, often related to an emotional or physical stressful event. Most often this stressful trigger is identified in the preceding days, that is 1 to 5 days before. It has a specific pathophysiology that likely reflects neurocardiogenic myocardial stunning, and it mimics acute myocardial infarction in presentation. Epidemiology of stress cardiomyopathy, it basically occurs in approximately 1 to 2% of the patients presenting with troponin positive suspected acute coronary syndrome or suspected ST elevation MI. It is more common in females, that is 90% more common in females, and the mean age is 66.4 years, which is the postmenopausal time in a female. Now the triggers of stress cardiomyopathy. 30% cases there is an emotional stressor. That is maybe death of a loved one or assault, violence, natural disaster, which all of them have involving a sense of doom. Physical stresses are seen in 40 to 45% of the cases where there is acute critical illness, which can be in the form of surgery or severe pain, sepsis, exacerbation of COPD or asthma. And third is central nervous system disorder, that is seizures, ischemic or hemorrhagic stroke, encephalitis or meningitis, head trauma, press. So this is a gist of the pathophysiology of stress cardiomyopathy, in which, as we can see, that there are certain risk factors or predisposing factors which are already present, like female, postmenopausal, schizophrenia, anxiety, depression, chronic medication, substance use disorder, and there is an emotional stress or a physical stress, as we talked in the previous slide, and due to which there is stimulation of the hypothalamus and the pituitary, that is mainly the limbic system, and from which there is release of catecholamines and neuropeptide Y. Now these catecholamines and neuropeptide Y, they have direct cardioinhibitory effects on the myocardium, as well as it causes microvascular dysfunction, and which ultimately leads to stress cardiomyopathy.
What inhibits it causes? You said a cardio-inhibitory effect.
Yes, so basically, sir, in the left ventricle, there are beta 1 and beta 2 receptors which are present in the apex as well as the base. So the beta 1 receptors are more present on the apex. So in this disease, basically the catecholamine levels are increased to 3 times as compared to that of acute coronary syndrome. And so these catecholamines will overstimulate the beta 1 receptor on the apex, which will ultimately cause an inhibitory effect.
What inhibition occurs? How?
Inhibition of the contraction of the muscles, which will cause the apical ballooning.
Is it called direct inhibitory effect?
Direct
Is it called direct inhibitory effect?
by getting involved with the calcium channels and other various glycopeptides, which causes ultimately inhibition of the myocardium.
So you are trying to say that overstimulation is causing inhibition. That is what you are trying to say?
Yes, sir. Initially,
तो direct inhibition के अंदर क्यों है pathophysiology?
Sir, as the pathophysiology is not very clear and more insights are being formed in it, so initially, like one aspect is also there is a direct inhibitory effect also, and another one is by stimulating the beta 1 receptor. So it is.
So how catecholamine directly inhibit? Why or what? See, overstimulation तो हम किसी को ले जाओ. So what are other pathways? So direct inhibition myocardium करे, apex में करे, how?
Sir, in the literature it is only mentioned about the beta 1 receptors. That is the only.
Catecholamine will inhibit beta 1?
Sir, in very high doses, it is seen that it inhibits the beta 1 receptor.
That is absolutely new to me. No? I have never heard catecholamine inhibits beta 1.
So there is
overdosing test.
modulation of the receptor, beta receptor from GS type to GI type, that is stimulatory type to inhibitory type, which will cause the inhibitory effect. That is what is mentioned. So the catecholamine levels are substantially elevated in patients with Takotsubo, up to 3 times higher than those in patients.
And what is the role of neuropeptide Y? Exact role?
It is more involved in the microvascular dysfunction, which is mentioned. So the catecholamine levels are up to 3 times higher than those in patients presenting with acute myocardial infarction. 55.8% of the patients with stress cardiomyopathy had an acute former or chronic psychiatric or neurological disorder like anxiety, headache disorder, seizure, etc. Neuroimaging suggests increased blood flow in the hippocampus, brainstem, and basal ganglia. So consequences of high circulating catecholamine levels and enhanced sympathetic stimulation. So there is dysfunction of coronary macrocirculation as well as microcirculation. Transient LV dysfunction may result from the direct effects of catecholamines on the ventricular myocardium, which are known as neurogenic or catecholaminergic stunning. As I said, sir, the apical myocardium has more beta 2 and the basal myocardium has more beta 1 receptors. And at very high concentration, the beta 2 receptors switch from stimulatory to inhibitory signaling pathway, causing negative inotropy or stunning at the apex. These are the different variants of Takotsubo myopathy. The most common, that is 75 to 80% of the cases, is the apical ballooning, which is the typical variant, in which we can see that there is apical ballooning of the left ventricle and base is contracted. And it is basically associated with left ventricular outflow tract obstruction, LVOTO, and apical thrombus formation can also be seen in these cases. Second is mid-ventricular, in which the dilatation or ballooning is seen in the mid-ventricle, which is seen in 10 to 20% of the cases. Where severe left ventricular dysfunction and acute heart failure is commonly seen with this type. The third is basal or inverted, in which it is exactly opposite to the apical type, in which the basal part of the left ventricle is ballooned and apex is contracted. Fourth is biventricular, in which both the ventricles, which is very less common, and in which there is severe hemodynamic compromise and cardiogenic shock. And one more type is focal dysfunction, which is very rare, in which there is only outpouching or ballooning of only one segment, and it is very rare.
So why biventricular is very less common?
So there is no data regarding why it is very
is the proportion of beta to receptor ratio as compared to LV in RV? Very less.
Sir, it was not mentioned anywhere regarding this, but there might be a possibility that there is less distribution of as the function of LV is to account for that, so there will be more in that effect. So these are the same things which are seen in the LV angiogram, in which there is first you can see a cycle where there is ballooning of the apex here in the systolic phase. In mid cavity we see the ballooning. In the third figure there is basal ballooning, and in the last figure there is focal ballooning. Clinical features. First, the history of triggers. In 36% of the cases there is physical trigger. In 28% of the cases there is emotional trigger, and in 8% of the cases both physical and emotional triggers are seen. Postmenopausal women with acute or subacute onset of substernal chest pain is the most common presentation, that is more than 75% of the cases. Shortness of breath is present, dizziness. Shortness of breath is present in approximately 50% of the cases, dizziness in more than 25% of the cases, and occasional syncope in 5 to 10% of the cases. So, moreover, it mimics the presentation of acute myocardial infarction. Now, in further investigating, if we see the ECG, we will be able to see ischemic ST segment and T wave changes as seen in myocardial infarctions or acute coronary syndrome, in which ST elevation is more common than ST depression, and it is most commonly seen in the anterior precordial leads, similar to acute myocardial infarction. Other findings in the ECG can be seen, that is QT prolongation and T wave inversion. QT prolongation may also lead to ventricular arrhythmia and torsades. Usually the ECG changes develop 24 to 48 hours after the onset of symptoms or the precipitating stressful trigger. After ECG, the cardiac biomarkers, the troponin levels are generally less than 10 nanogram per deciliter, which are much lower than that of myocardial ECS. And pro-BNP levels are almost always elevated, with higher levels correlating with the degree of the ventricular wall motion abnormality. And so basically we can differentiate it from acute coronary syndrome. That first is the troponin levels are less than the myocardial infarction, and the BNP levels are higher in comparison to coronary syndrome. Now, 2D echocardiography, in which there is regional LV wall motion abnormality beyond the territory perfused by a single coronary artery. So that is first point, which can be differentiated from coronary syndrome. And secondly, that it is reversible in nature. Second is that global LV akinesis or dyskinesis with classical ballooning at the apex. So as you can see in that image, that in the LV there is classical apical ballooning with a contractile base. So that is the finding in Takotsubo cardiomyopathy. Another thing which can be found in echo is left ventricular outflow tract obstruction. We can find a jet in the aortic valve. Due to basal hypercontractility, we can find LVOQ. And mitral regurgitation can also be present due to systolic anterior movement of the anterior mitral leaflet, as seen in the case of hypertrophic obstructive cardiomyopathy. Further, cardiac MRI is recommended for it to differentiate from its two close mimickers, that is myocardial infarction as well as acute myocarditis. In cardiac MRI, late gadolinium enhancement on cardiac MRI is generally absent in Takotsubo cardiomyopathy, in contrast to MI, in which it is intense. So as you can see in the first image in MRI, there is apical ballooning and basal hypercontractility in the systole, that is seen in MRI. And if we see the MRI in myocardial infarction, then we can see the late gadolinium enhancement in the figure, in the second figure, in which the arrows are shown. While in acute myocarditis, the patchy late gadolinium enhancement is seen.
So at what time of presentation you will subject patient for cardiac MRI?
So generally, as the patient's presentation will be very close to MI, so the guidelines suggest that we have to go for either thrombolysis or PCI or coronary angiogram, as there is ST elevation and chest pain. So once after everything is done and the coronaries are normal, then we can, after stabilizing the patient, we can go for a cardiac MRI. After everything, patient
after stabilization.
After stabilization, yes. When to suspect TTC? TTC is suspected particularly when the clinical manifestations and the ECG abnormalities are out of proportion to the degree of elevation in the cardiac markers. So if we see that there is tall ST segment elevations in leads involving more than one coronary territory, and clinical manifestations of the patient are severe but the troponin levels are probably less than 10, then we can suspect it. So diagnosis requires ECG, troponin levels, coronary angiogram, and serial assessment of the LV function by echocardiogram. And cardiac MRI is recommended to exclude myocarditis.
Has anybody done levels of noradrenaline and adrenaline? Because ultimately beta-catecholamine is 3 times more elevated than patient. Anybody has done levels of noradrenaline and adrenaline at a time? Suppose you have already diagnosed now with this ECG wise, echo wise, and you have done angiography, echo showed apical ballooning.
Yes.
Now you have suspected now this is cardiomyopathy, right? So a beta-catecholamine level, sir.
For the initial study, we see that it is 3 times higher than that of the acute coronary disease. So troponin levels are measured initially for the study purpose, but the importance of those levels for follow-up diagnosis and that is not yet established.
Another issue is it lacks the specificity. It will be having many all stress-related issues, not only Takotsubo, right? So
yes.
It will not give you diagnostic information.
This is the Mayo Clinic criteria to diagnose Takotsubo cardiomyopathy, in which 4 aspects are present and all of them should be present. First, as we mentioned, that there should be transient hypokinesis, akinesis or dyskinesis of left ventricular with or without apical involvement. The regional wall motion abnormality extend beyond a single epicardial vascular distribution, and a stressful trigger is often but not always present. So first is to the echo. Second is we do the coronary angiogram of the patient, and the CAG of the patient is either normal or there is absence of obstructive coronary artery disease, or there should not be any angiographic evidence of acute plaque rupture. Third is ECG criteria, that is new ST segment elevation or T wave inversion, or modest elevation in cardiac troponin. And fourth is absence of pheochromocytoma or myocarditis.
In ECG we cannot suspect because in echo you said beyond the vascular distribution. So similarly.
Yes, sir. Similarly, we can see that the elevations are not being localized to a particular coronary artery, so we can again suspect.
So what is the description of this transient? How many days? How many weeks?
21
Less
days.
than 21 days is according to the definition, but it is seen that it might take 4 weeks, 4 to 6 weeks also for the LV dysfunction to get normalized.
એટલે કોઈ એક પહેલા ઇન્સ્ટન્સ એક ડાયગ્નોસિસ ના કરી શકે.
No, sir. It
It's
is
not
required
possible.
serial echo.
Only
It is a
serial
retrospective
incidences.
Somebody would not thromboline.
Yes, sir. So, according to if the patient goes to a non-PCI center and if there is ST elevation with chest pain and the cardiac troponins are also positive, so according to the guidelines, it is thrombolysis is to be done. So, after thrombolysis, again retrospectively, we can check for the echo LV function and decide. So, thrombolysis is justified, sir. It is not that we should not thrombolyze if we have even a doubt of Takotsubo cardiomyopathy.
It is not harmful.
Not harmful, sir. We
Of course, it is
So,
harmful, but
it is harmful.
the
Yes,
bleeding-
but you have to.
બ્લીડિંગ થાય તો તમે
Bleeding
પેલા
list,
થઈ
the
શકે.
bleeding list तो always remain.
એ તો બધા
But according to the guidelines of myocardial infarction, sir, we have to.
so in the guidelines of myocardial infarction that Dr. Lalji is not present, he presented in that article it is very clearly mentioned if there is an LVF or shock, then you must do echo. And if you do an echo here, if you are skillful enough to pick the Takotsubo, then you will not thrombolyze.
You said that angiography in this patient will be a normal. So, suppose if you thrombolyze, you may do more harm.
Yes, sir. So if the patient presents to a PCI capable
important step to that. Nowadays, it's recommended. The way you can do this.
In non-PCI capable center, there won't be any option apart from thrombolysis. There are a few cases seen in which there is pheochromocytoma induced LV dysfunction also, which is very similar to Takotsubo. So ruling out pheochromocytoma is also included in the Mayo Clinic criteria, as catecholaminein levels are increased in pheochromocytoma. So absence of pheochromocytoma or myocarditis is considered to be a diagnostic criteria.
So ultimately you are doing meta-nephrin moment.
Meta-nephrin.
If you want to roll out, you have to do. So ultimately you are doing the job.
Indirectly, I will
This is the inter-TAC diagnostic score, in which there are various points. There is female, emotional trigger, physical trigger, absence of ST depression, psychiatric disorders, neurological disorders, and QT prolongation. Each of the points has been given a particular score, and the presence of each of those points will be added. And if the score is more than 50, then we can consider the diagnosis of Takotsubo. And if the score is less than 31, then the specificity for acute coronary syndrome is known. These are other criteria like the Heart Failure Association, European Society criteria, and International Takotsubo diagnostic criteria. Most commonly used is the Mayo Clinic criteria, and this has some extra points in each. That is, in Heart Failure Association criteria, BNP levels are included, and also the recovery of ventricular systolic function is included. And in International Takotsubo criteria, other points are included, which are that is the stressors at the postmenopausal women are predominantly affected. So 2 or 3 different points are included, but the most commonly followed criteria is the Mayo Clinic criteria. So this is basically the approach to the patient with chest pain. So the patient presents with chest pain or dyspnea, we go for ECG first. ECG shows ST elevation. So here it is considered that it is a PCI capable center, so we go for coronary angiography. In coronary angiography, if we find the coronary culprit lesion, which explains the regional wall motion abnormality, then that is the diagnosis is considered to be ACS. If no, then first we will see for the red signs of acute myocarditis. Whether there is signs and symptoms of viral infection, elevated ESR or CRP, or pericardial effusion. If these red flag signs are present, then we will go for a cardiac MRI first to rule out myocarditis. And if these red flag signs are absent, then the diagnosis of ATS can be considered. So here we can start suspecting of Takotsubo, and then on the follow-up to DECO, if there is persistent RWMA, then again we have to go for cardiac MRI whether to see that event was myocarditis or acute coronary syndrome. And now if there is no persistent RWMA follow-up, then the diagnosis of Takotsubo is confirmed. So this is in the case of ST elevation. Now if the patient has having non-ST elevation, so in that first we will go for the inter-TAC diagnostic score. And if it is more than 70, which has got a very high probability of Takotsubo, then we will go for a 2D echo, in which we will find the specific.
ST elevation, what you find in ECG then?
Also ST depression or T-wave inversion with troponin positive.
You say that depression is not according to criteria, ST depression is not seen.
No sir, it is less common.
Less common.
Less common.
It can be seen sir. T-wave inversion.
What amount of ST depression you find?
In how much percentage of
They
patients?
have what amount? 1 segment, 2 segments?
So that is according to the 1 mm, more than 1 mm depression is considered, which is considered positive. So in this there is no emergency of a coronary angiogram or thrombolysis. So in this, after ruling out and if the patient is stable, then we will go for a CT coronary angio, and then we will decide whether the patient has CAD or not.
So which ECG changes will invariably present? દરેક ટાકોત્સુબોમાં હોય છે.
So most common is ST elevation, but it is not in the case that
Simple. Tachycardia.
Yes, tachycardia.
Tachycardia will always be there in all Takotsubo.
Complications of Takotsubo cardiomyopathy: acute heart failure or cardiogenic shock. Systolic heart failure is most common in acute phase. And cardiogenic shock can also, or heart failure can also be secondary to the LV outflow tract obstruction and mitral regurgitation. LV outflow tract obstruction is another complication. Arrhythmias, which includes atrial fibrillation in 5 to 15% of the cases, ventricular arrhythmias in 4 to 9% cases, and torsades observed in the settings of QT prolongation. LV apical thrombus leading to thromboembolism is another complication. Now, management of Takotsubo cardiomyopathy. As it is a transient disorder, the mainstay of the management is supportive therapy. Resolution of the trigger usually results in rapid resolution of symptoms, and ECG monitoring patient needs to be admitted to a cardiac or medical unit with continuous ECG monitoring, because there is risk of arrhythmias, particularly if the patient has already QT prolongation seen. In absence of QT prolongation or arrhythmia, monitoring for 48 hours is considered sufficient. So we can just stratify the Takotsubo cardiomyopathy like low risk or high risk. If the EF is more than 45 or at least more than 35, then we can consider early discharge strategy. While if any of these is present, that is heart failure is present, apical thrombus is seen, EF is less than 45, and cardiogenic shock, if the patient presents in cardiogenic shock, then these are considered to be high risk cases of Takotsubo. So basically the management, first we have to decide whether the patient has more predominantly heart failure symptoms or shock symptoms. So first, if the patient presents with pulmonary congestion without hypotension, then the treatment is aimed at reducing the venous return with venodilators and diuretic agents, how the heart failure is managed to the acute heart failure. Second is for patients with hypotension and shock. The treatment differs substantially whether or not the LVOT obstruction is present or not. So in patients with hypotension, first we have to check whether LVOTO is present or not. If there is absence of obstruction, then inotropic drugs like dobutamine and dopamine can be considered to increase the cardiac output. However, even if there is no baseline LVOTO, a short-term follow-up assessment is needed to ensure that there is no addition of LVOTO of an inotrope did not cause obstruction to occur. If inotropic agents are not sufficient, then vasopressor, that is norepinephrine or vasopressin, should be considered at the lowest possible dose. As we know that the primary pathogenesis is caused due to this, so at the lowest possible dose, or as an agent to bridge to mechanical support with a left ventricular assist device, or as a bridge to recovery. So mainstay in the patients with hypotension not having LVOTO is inotropic support, that is dopamine or dobutamine. If it is not possible to maintain the patient with those drugs, then we can add the lowest possible drugs of vasopressor drugs, just for a bridge to recovery or a bridge to mechanical assist device. Now, in patients with shock and LVOTO, inotropic agents need to be avoided as it will further worsen the LVOTO obstruction by augmenting the basal hypercontractility. So if severe LVOTO is present, then it is very challenging to manage, and if patient is not bradycardic, then the use of low-dose short-acting beta blocker like esmolol or metoprolol can be attempted to reduce the LVOTO obstruction, which will ultimately improve the cardiac output. So this is the gist of management of stress cardiomyopathy. If the patient presents with pulmonary congestion and normal BP, then we will treat as a systolic heart failure with venodilators, diuretics, beta blockers, and ACE, ARB or RB. And if the patient presents with cardiogenic shock, then first we will see whether LVOTO is present or not. If LVOTO is present, then we will avoid inotropes as it will worsen the LVOTO. So in those cases, we will go for cautious IV fluid management, beta blockers, and if the LVOTO is absent, then we will go for inotropes. And in refractory cases, we will consider mechanical LV support like IVP, Impella or ECMO. Treatment with beta blockers may protect against malignant arrhythmias and cardiac rupture. If there is systemic anticoagulation, should be considered in patients with large areas of A kinesis, and it is continued till the LVEF has recovered. And if there is thrombus already present in the echocardiography, then treatment is recommended for 3 months. The use of ACE or ARBs should showed a marginal benefit at 1 year survival, and attention should also be given to assessment of psychiatric problems and substance abuse that may persist and continue the risk of recurrence and long-term outcomes. Prognosis. Stress cardiomyopathy has an in-hospital mortality of up to 5%. Recovery of LV contraction is gradual, generally occurring over 1 to 2 weeks, although the process may be rapid within 48 hours or delayed up to 6 weeks. And recurrence are common, 2 to 4% per